Dialogue with a Doctor, featuring Southwest Florida's leading physicians, hosted by Dr. Gregory Leach and Jim Wood.
Good evening and welcome to Dialogue with a Doctor. We're here this evening with Dr. Raymond Phillips, and we're welcoming him back. He has been with us before. He is a practicing gastroenterologist in Naples, Florida. And we're going to talk this evening about hepatitis C, a topic which is hot these days, according to Dr. Phillips. But first, we'd like to know a little bit about you and where you came from. And
Okay, well, thanks, Greg. It's good to be back, and appreciate the opportunity to be able to speak with you both. I'm a gastroenterologist. I'm board certified in gastroenterology as well as liver disease. I went to college at Princeton. I went to medical school at Washington University in St. Louis. I did my medical internship at Philadelphia at Jefferson Hospital, and I did my residency there. And then I was chief resident at Jefferson Hospital as well. At that point, I came on active duty in the Army as a result of an ROTC scholarship that got me through college. And I was an internist for 2 years at Fort Leonard Wood, Missouri. And then after that, I did my gastroenterology training at Walter Reed Army Medical Center for 2 years. And then I was on the staff at Walter Reed for 2 years after that as an assistant professor of medicine and also at the Uniformed Services for Health Sciences in Bethesda. As I said at the outset, I'm board certified in gastroenterology as well as liver disease, and that's what we're interested in tonight, which we discussed earlier. You know, hepatitis C is in the news, but it's been in the news before, but on this particular occasion, there's several different reasons why it's receiving much more attention.
let me ask you, because there is confusion amongst patients about even what hep means or is, and now we're talking about hepatitis C. So can you clear that up for us or for patients?
Well, whenever you say the word hepatitis, you know, everybody sort of leans backwards and they get concerned. But it's just a short-term, a short word to mean inflammation in the liver. And then it's a matter of determining what is the cause of inflammation. In general, there are several different causes. There's viruses that can cause inflammation in the liver. And the principal viruses are A, B, and C, but it goes on to D, E, F, G. But the principal ones are A, B, and C. There are other causes for inflammation in the liver. The most common is alcohol-related issues. There's another entity that's becoming the most common cause at this point called non-alcoholic steatohepatitis, or NASH, or NASH for short. And that's becoming one of the most common causes for inflammation in the liver or hepatitis. We'll talk about it some other occasion, because in another 10 years it will be the most common cause of hepatitis in the United States. But for today, the issue is hepatitis C. The point being with the word hepatitis is that represents inflammation, and the C just indicates that, hey, this is inflammation related to a virus, which we designate as type C.
But what are the causes? I mean, you can get it from blood transfusions, drinking water, or
well, that's a good question. It is a virus like other viruses, right, and there's different means by which viruses are transmitted. Right. Hepatitis C is very characteristic in that it's typically transmitted through blood contact. Blood contact would be before blood products were screened for hepatitis C. Blood transfusion was one means of getting hepatitis C. But the more common cause was the sharing of needles of injection drug use, and sharing needles with an individual that had the hepatitis C, and then injecting oneself with a contaminated needle and injecting the virus as a result. So hepatitis C is unique in that it's only blood contact. There's a rare circumstance where you can get sexual contact as a means for contracting this virus, really, really rare. So the most common is blood contact. And secondary causes, for example, if you're living in a household and you share toothbrushes or you share razor blades, you can potentially transmit the virus that way, but that also is through blood contact as a result of traumatizing the gums and causing a little bit of blood on the toothbrush or are traumatizing the skin in the course of shaving and leaving a little bit of blood on the razor blade. So it's blood contact. So those individuals that have hepatitis C, they don't have to worry about contracting this as a result of sharing drinking utensils or eating utensils or sharing plates or hugging or kissing or anything of that nature. It's through blood contact.
And I read, how about drinking water? Is it because of the bacteria?
Well, wait a second, man. Yeah, listen to what I said now. As far as, now, you can contract hepatitis A, which is another virus, through drinking water or contaminated water. But hepatitis C is blood contact.
It's blood contact.
Just purely blood contact. And just for completeness' sake, hepatitis B, which is not very common in the United States, that also is blood contact. But just for the sake of clarity, we're just sticking with hepatitis C, and it's through blood contact exclusively.
So, go on.
I was going to say, do people who are married refrain from intercourse if one has hepatitis C, or is that controversial? Or?
No, it's not controversial, and a large study was conducted to look at that, and well, the NIH followed a large number of married couples that were discordant. That is to say, one couple had the virus, the one member of the couple had the virus, the other did not, and they were followed over a long period of time, and it just didn't occur over the course of 10 years that the other partner would contract this virus. Through routine sexual contact, it is extraordinarily rare. The specific numbers were, there was like 2,000 couples, and after 10 years, one couple had the experience where they both had hepatitis C at the end of 10 years. So it's a rare issue, and that's why I'm just emphasizing blood contact. Now, as far as blood contact, common except in the context of intravenous drug use, which is becoming less and less common in the United States, but in the 1960s and 70s, that was really common. During the Vietnam era and following that, there was a lot of returning troops who were addicted and used IV drugs, and the context of cultural changes at the time, there was a little more permissiveness, and people were experimenting, and a lot of people experimented with IV drugs at that time, and as a result had the potential of being exposed to the virus. The trouble with this virus is once you get it, you rarely have any symptoms. That is to say, when you initially get the virus, it's rare to get any typical symptoms that you might think of in terms of jaundice with yellowing in the eyes or any kind of profound symptoms at all. Most people just feel a little bit tired. And as the years pass, that's really the principal symptom you would see would be tiredness. And so this virus, which has a predilection for the liver, that is to say that's where it infects, can cause a steady inflammation over the course of years and years without anyone really being aware that there's an ongoing infection.
So even though tiredness is a symptom, many patients don't have any symptoms.
The majority of patients have no symptoms. They don't have any symptoms until there's been enough accumulation of injury to the liver that you get enough accumulation of scar tissue that then you start getting damage that begins to appear as a result of failing of the liver itself. And these kind of symptoms would be things like jaundice or development or retention of fluid, so retention of fluid in the abdomen or the extremities, so the swelling of the feet, or the potential of developing large veins in the esophagus that can sometimes bleed. So these are events that occur after a great deal of injury is accumulated within the liver and scar tissue, and in years past when we didn't have effective therapy for hepatitis C, it was, well, why make a grand effort to try to diagnose this? But over the years, we've had steady progress and success as far as treating hepatitis C.
Is your routine blood work when you go and get a physical, do they check for hepatitis C?
No, they don't. And will be checked for on a routine physical, your blood count, kidney test, the presence of inflammation in your liver by measuring particular enzymes that are called ALT and AST. And those are routinely checked. And if there's inflammation in the liver, those enzymes will be increased. The ALT and AST will be increased. They may not be increased to great degrees, but any increase at all is an indication of some degree of inflammation in the liver itself and warrants evaluation. Now, too often in the past, there would be a slight increase in these liver tests, and it wasn't terribly high, and the physician would reassure the patient, oh, it's nothing to worry about, we'll check it again next year. Well, the years would come and go and be checked again and again, and it'd always be a little bit increased, and it'd be sort of ignored. But any increase in the liver enzymes itself indicates some degree of inflammation and warrants evaluation.
So if a patient were infected with hepatitis C virus, how many patients can eradicate it from their body? How many patients don't? And of those, how often does it actually ruin the liver?
Well, if you become infected with hepatitis C, the 80 out of the 100 people that are initially infected with this will go on to have a chronic infection. 20 out of that initial 100, their immune system will be sufficiently effective that it'll eradicate the virus. But the overwhelming majority of people who have this virus will develop a chronic infection. So you got that 80 out of 100 that have a chronic infection. Out of that group of 80 now, over the next 20 to 30 years, about a fifth of them, 16, will go on to develop scarring of the liver, cirrhosis of the liver. And of that 20% that develops scarring in the liver, another 20% will develop liver failure and require transplantation, or liver cancer and can die from it. So there are consequences of this ongoing infection, but the majority of people will not get cirrhosis or something dreadful like liver cancer or end in failure of the liver requiring a liver transplantation. But when you're talking like 4 million people, 4 million adults in the United States that have this infection, and the overwhelming majority do not know they have this infection, and you're going forward, you're talking about potentially large numbers that can get cirrhosis and liver failure and liver cancer. Mm-hmm. And that's why the CDC and this recent announcement encouraged everyone who was born after 1945 and before 1965 to go ahead and be screened in the context of routine physicals for the presence of hepatitis C, regardless of whether there's any increased liver enzymes or not. You might say, well, why in the world would they do that? Well, before, the strategy had been to identify people who were at high risk for being exposed to blood. That is to say, individuals that had had a blood transfusion, individuals that had IV drug abuse. But time goes by, people forget about transfusions, and there are very few patients who willingly volunteer that they use IV drugs when they're a teenager. Right. So there was so what we're finding is many people are at risk but weren't being diagnosed. And now with realization of the health consequence, but more importantly the capability now of treating these individuals successfully, we feel it's particularly important to identify individuals with hepatitis C and offer an opportunity to be able to be treated before there's irreversible damage to the liver.
So who do you treat?
Well, that's a good question. First you got to identify an individual, and just to follow up your question, Jim, how do you? Your basic question was, well, how do you diagnose this? Well, I just said you may be alerted to the presence of inflammation by the presence of elevated liver enzymes, but to really detect whether you've ever been exposed to this virus, it's a blood test where we check for antibodies that your body has developed in response to that infection. And if you have these antibodies, there's a real likelihood you got this infection. And but as I said, that doesn't necessarily mean 100% you have an infection. If the antibody does indeed show to be positive, it's worthwhile to do more detailed viral tests where we can actually see the presence of the virus and determine if the virus is present in your bloodstream or not. And if it is present, then we can actually break down what variety of virus it is, because the hepatitis C there's different strains, like different breeds of dogs. Mm-hmm. Well, there's genotype 1 through 6. And in the United States, genotype 1 is the most common. 70 to 75% of infections in the United States are genotype 1.
Can this be transmitted through mosquito bites?
Well,
I got off the subject
theoretically, yes, indeed, it could be
okay.
if a mosquito happened to land on someone who had this virus, and then they landed on someone else who and they took another blood meal. It's conceivable that they could transmit this virus. And I don't believe there's ever been any reported documented cases of that. But any blood-borne virus can be transmitted that way. So it's just a...
Well, we're gonna take a short break, and then we'll be back to talk more about hepatitis C virus and also about treatment for hepatitis C and new treatments. So, see you in a minute.
I had been a practicing orthopedic surgeon for a number of years, and I thought that I was invincible to the multitude of medical problems I saw around me every day. Was quite shocked when I received a phone call telling me that I had cancer of the prostate.
Dr. David Spellberg of Naples Urology Associates is the local specialist in treating prostate cancer with the new CyberKnife radiation treatment.
Once I got myself together, was to do as much research as I could, and what I was looking for was a treatment that would give me the least risk of complications and side effects, and that's where the CyberKnife came into the picture.
Advanced CyberKnife technology, precise. It sends just the right dose of radiation to the cancerous areas. Fast. Each treatment is only 1 hour, non-invasive. This outpatient procedure has almost no side effects.
The day after my treatment, I was out playing golf, and I'm looking forward now to continuing to enjoy a long and happy and comfortable life thanks to the care of my team of doctors and to the CyberKnife procedure.
Learn more about CyberKnife and Dr. Spellberg. Call today.
Welcome back to Dialogue with the Doctor. Once again, we're Raymond Phillips, a practicing gastroenterologist in Naples, Florida, and we're talking about hepatitis C virus infection. So far, we've talked about how you get it, what it is, what kind of breed it is. Don't know which breed is the bad breed, but and now we'll talk more about treatment.
All right. Again, just to sort of echo what you're saying, there's different varieties of hepatitis C, genotype 1 through 6. Genotype 1 is the most common in the United States, and that's the one that's most difficult to treat. It's most resistant to treatment. And over the last 20 years, treatment initially with interferon, which is an injection, about 10% of people would be cured with that. And that was an injection 3 times a week. And then in the mid-90s, there was a prolonged form of interferon that was developed that allowed once-a-week injections. And then later in the 90s, the use of a drug called ribavirin in conjunction with this long-acting interferon increased the success rate up to about 35% or 40% cure rates in individuals with this stubborn genotype 1 hepatitis C. And that's the way things stood for almost these past 10 years until this past year with the greater understanding of the hepatitis C virus and sequencing of its genome and developing targets for attacking the virus. Now in this last year, a new medication was released to be used in conjunction with the interferon and ribavirin that now has increased the success rate up to 70%. So there's a 70% chance of being cured of this virus as a result of using this current therapy. But it's an exciting time for therapy because in the next year, 2 or 3, other forms of therapy are going to be approved and released. And the hope is to be able to create a treatment program that has a reduced amount of side effects, that's shorter, better tolerated, and doesn't require necessarily an injection and in particular not to include interferon, which is a difficult medication for people to tolerate over a long period of time. So we've had a lot of success here recently, and there's a tremendous proliferation of studies looking at different combinations of medications to see what would be most effective and most best tolerated in fact, we're doing some of these studies right now. We're doing one study that looks at individuals who have flat not responded at all to hepatitis C therapy. And then we're going to be beginning another study in the fall of 2012, the next 2 months, that involves individuals who responded to therapy but then relapsed. Because these are individuals that need attention and are a little bit more stubborn as far as treatment, even with this newest treatment available this past year. So we are conducting studies in hepatitis C, and we're real excited about these, the potential.
How long of a treatment does it take till you find out that you've turned it the other way?
Well, the current therapy is up to 1 year.
1 year?
It's possible in the course of monitoring therapy, some individuals respond very well. The virus goes away very rapidly, and for those individuals, we can adjust the duration of therapy so they don't have to get it quite as long as 1 year. And that's an innovation in these last several years. By using the level of virus as a guide, we can use that to determine how successful we are during the course of treatment. And correspondingly, if we're not responding to treatment, we can use as an indication if the virus is not going away, there's no point in continuing a therapy that's not being successful. So we can know to stop a treatment program sooner and not subject a person to a long course of potential side effects for a futile effort.
What is the treatment? Or
Well, the current treatment right now is using a once-a-week interferon. And I should digress for a moment, just tell you what interferon is. Kind of interesting drug. It's actually it's actually a product your own body produces. Interferon is a substance your body produces when you're exposed to a virus. And it revs up your immune system. It revs it up so that your body can more effectively defeat any kind of infection, in this case a virus. And typically what occurs in the course of revving up your immune system, there's a number of other chemicals that are released that make you tired, give you a fever, make you achy, make your muscles ache. So all the symptoms that you get with the flu is because of this particular chemical your body is producing to enhance your immune system. And then as a result, we have a visitor here, but I'm sure he can find his way. As a result of this interferon, people have a lot of symptoms that go on for some time, and now we're giving it back in industrial quantities. That is to say, in an injection. So there's a lot of things to be anticipated. You expect to get tired and achy and have a low-grade fever, but usually that goes away after a week or so, and we found ways of minimizing the symptoms by using medications like Tylenol or Advil to minimize the worst of it. And by anticipating what persons would experience, we can prevent the worst of it. And most people can get through treatment successfully.
How frequently is interferon given?
It's given once a week. That injection lasts for an entire week. And now the other parts of the therapy, ribavirin, is given twice a day. It's effective. It actually attacks the virus itself. The third medication that's available is either called boceprevir or telaprevir. Actually attacks the virus directly as well, prevents it from being able to reproduce as efficiently as it should. So the combination of all three medications, enhancing your immune system, attacking the virus directly, inhibiting its capability of reproducing, that combination of strategies collectively is very successful as far as getting the rates of 70% cure rate that we have right now. But if you had a pneumonia and I told you, hey, you're going to get better 70% of the time with this, you would not be thinking much of it. You wouldn't think much of me. And so, we need to get up to the rates of 95, 100% cure rate, and we need to do it with minimal side effects. And that's what's driving the pharmaceutical industry right now, to really find a combination of therapies that would achieve those goals.
How are these new drugs that are available today, are they only in testing mode, or are they available?
No, these drugs that are available right now, they are available. They're approved by the Food and Drug Administration. They have been shown to be safe and effective in the environment. And that is to say, supervised by gastroenterologists or infectious disease specialists. And when I say gastroenterologists, I mean by that as well a liver specialist. A hepatologist is the formal name. But that medication is approved right now. It's available right now. And it's just the hope is that we will continue to get additional therapy over the coming years that will enhance our success rate and reduce the side effect incidence.
How about the baseline health of the person to begin with? I mean, what can a patient do who has hepatitis C and is being treated by you? What can they do to increase the probability of success in terms, do they smoke, do they not smoke, are they eating well, all of these things? How does that...
There's a lot of things an individual can do that make a big difference as far as injury to the liver. Avoiding alcohol. It used to be thought that, it's okay to take a drink or two a day with hepatitis C. As it turns out, if you're completely abstinent, if you're a teetotaler, it much reduces the incidence of damage to your liver. So it's important to be completely abstinent from alcohol. The other point is that if the person's weight is as close to normal as possible, it's very important, because when you carry extra weight, some of that fat is stored in the liver, and the fat that's stored in your liver can have an irritating and inflammatory effect on the liver that can enhance the inflammation that's provoked by the virus itself. So by doing those two things, avoiding alcohol, keeping the weight reduced, and exercising regularly, those three things together can make a big difference as far as preventing accumulation of damage to the liver. Now, listen to what I'm saying. It doesn't kill off the virus. It just minimizes the damage done to the liver as a result of the virus. So it has value in terms of preserving the function of the liver. Everybody, and when I talk to them about this, isn't there some kind of pill I can take? How about that milk thistle? I'm sure that works just fine. And that has been looked at. That reduces inflammation to a degree, but it has no effect on the hepatitis C virus. And that particular product, milk thistle, has been undergoing sort of systematic trials that have been very disappointing in terms of its effects.
Well, can you tell us briefly where you're located and where your practice is for our patients?
Well, our practice is on 1064 Goodlet Road. It's in Colonial Square, in the downtown area. We have offices also in Marco Island as well as in Bonita Springs. I practice with Dr. Lebersky, Dr. Marks, as well as Dr. Randall, Dr. Khatib. And any one of us are specialists in liver disease and would be happy to address or answer these questions if it comes up.
So if we refer to you and you're busy, somebody else can help.
Yeah, you got an equally qualified person available to help you out on this particular issue. But we certainly make an effort to accommodate individuals with this, because there's a lot of anxiety associated with this, and with a lot of things in life, once you have some understanding of what's involved and at least a clear-cut plan in terms of how to address it, people feel reassured and more confident that it can indeed be treated successfully.
Right.
We'd like to thank Dr. Phillips for coming again to our show this evening, and we would also like to invite him back for another show. And I think we've learned a lot about hepatitis C, and I think we will have patients now coming in now that they know more and feel more comfortable, I think.
Well, it makes a big difference, Greg. If you have an understanding of the medical problems and it's reassuring.
Dialogue with a Doctor, featuring Southwest Florida's leading physicians, hosted by Dr. Gregory Leach and Jim York.
Good evening and welcome once again to Dialogue with the Doctor, and we're welcoming back Dr. Raymond Phillips, who's a practicing gastroenterologist in Naples, Florida. He's been on the show before, and we like having him because he has a lot to say. This evening, we're talking about irritable bowel syndrome, ulcerative colitis, inflammatory bowel disease.
Yeah, okay.
That's the subject. But we've all heard of colitis and those entities, but that's the category we're talking about this evening. We'd like to welcome you back.
And I know you've been on before, but I'd like you to just tell us a little bit about yourself, your
Oh,
background.
Sure, Jim. Well, as you know, I'm a board-certified gastroenterologist. And to achieve that, I mean, I went to college at Princeton University, and I attended Princeton on an ROTC scholarship. And later, I went into the Army. But after Princeton, I went to Washington University Medical School, and from there, I went to Philadelphia. I went to Jefferson Hospital, and there I did my medical residency for 3 years. And the 4th year, I was selected to be chief resident. It was that point I went in the Army on active duty, and I was assigned to Fort Leonard Wood, Missouri. And at Fort Leonard Wood, Missouri, for 2 years, I was an internist. I was then selected to go to Walter Reed for gastroenterology training. And after 2 years of training at Walter Reed, I was then selected to be on the staff at Walter Reed, where I was there for an additional 2 years. And while there, I was assistant chief of the department, but also assistant professor of medicine at the Uniformed Services for Health Sciences at Bethesda. And in 1991, I came on down here to practice, and I practiced with Dr. Lebersky, Dr. Randall, Dr. Marks, as well as Dr. Petit.
And your offices are located?
Yeah, our office is on Colonial Square, 1064 Goodlet Road, downtown, and we have a satellite office in Bonita as well as in Marco Island.
So tell us a little bit about it, inflammatory bowel disease, what it is, and et cetera.
Inflammatory bowel disease is the general terminology we're talking about, but over the years it had been described as colitis, inflammation of the colon, and the name had been kind of vague, but just referring to a collection of symptoms of urgency, diarrhea, bleeding, and over the years it became clear, particularly in the 1930s, that there were two varieties of inflammatory bowel disease. There's a variety that came to be known as Crohn's disease, named after a Dr. Crohn in the 1930s. And then at the same time, it was recognized as other entity called ulcerative colitis. The two are distinguished from one another in that ulcerative colitis is just an inflammation of the colon, and Crohn's disease is an inflammation that can involve the colon, but the entire GI tract. Now, hardly anyone knew about inflammatory bowel disease, and the only ones who cared were the patients or their families and their doctors until the 1950s, when President Eisenhower, he came to be diagnosed with Crohn's disease. And it was a difficult time for him because he had a very, very severe variety of Crohn's disease that led to obstruction, a small bowel intestinal blockage. He was hospitalized at Walter Reed for 6 weeks, lost 40, 50 pounds. It culminated in an operation in 1956 where there was a debate intraoperatively about what was the best kind of operation for the President of the United States. And there was discussion between the chief of surgery about doing a particular operation, and they called in the chief of gastroenterology at Walter Reed for his opinion about what would be the appropriate operation. Well, with the President's open abdomen, they had quite a discussion about what was the appropriate operation, and the surgeon said, by God, I'm going to do the surgery I've been trained to do. And he did his surgery, and fortunately it's successful. It wasn't the surgery that the gastroenterologist recommended. The surgeon went on to become Surgeon General of the United States. The gastroenterologist was assigned to a place out in Alaska after that. So there's consequences sometimes of making the right recommendation, at any rate, after that, Crohn's disease became very well known, and with the availability of cortisone in the 1950s, the discovery of it, and the availability of anti-inflammatories, oral ones such as sulfasalazine, there was for the first time therapy for both of these conditions, and it was thought we had a cure, that with steroids that we could cure this. And it became pretty clear quickly that steroids were a little bit of a trap. You can improve the symptoms, but you would not cure an individual. and the individual would invariably relapse again and suffer all the consequences and side effects of steroids. And over these last 40 years, therapy has not been that successful because we didn't have a very good understanding about what was causing ulcerative colitis, Crohn's disease, and which I'll now just call inflammatory bowel disease. We didn't really have a good understanding of what was provoking it, so the therapy was a little bit haphazard. But we did understand that there was the immune system that was provoking this inflammation, your immune system believing there was an infection or something not right within the GI tract, attacking that area, leading to inflammation, and using drugs like steroids, but more recently drugs like 6-mercaptopurine, azathioprine. It was shown we could calm down the immune system. And then very, very detailed studies of the immune system were then done in the 1990s that finally led to the development of more successful drugs here in the 2000s. These drugs being a totally different class of medication. One's called Remicade, the other's called Humira, and we'll talk more about that in just a bit. But the theme I wanted to get as we did basic science and understood how the immune system was the stimulus and the cause for this inflammation and what was driving this inflammation, a number of studies were looking at it and trying to discover what was the trigger, what provoked this inflammation, what sustained it. And the theories that had been present for years, that this was a psychological issue or that there was deep interpersonal problems that provoked this and manifested in the GI tract, it came to be realized that this just wasn't the full issue. Stress could trigger problems, but was not the cause of the inflammatory bowel disease.
Smoking or any of that?
Well, a number of things were,
Sanitation or
some
food?
of things were looked at. A number of things were looked at. Everything was looked at because the understanding was so poor. Ethnicity, smoking, living conditions, latitude, many different things were looked at, and a number of trends developed. Ethnicity seemed to play a role initially. That is to say, Jewish populations were affected more predominantly, but that's become less and less of an issue. It seemed to be a function of latitude. The further north you lived, the more frequent it was. It seemed to occur in the big city rather than on the farm or out on a smaller environments, less urban environments. And so a lot of confusing factors. Smoking seemed to be, I hate to say it, beneficial in some ways, but at least for ulcerative colitis. But so the difficulty with this is that the understanding wasn't there. There was no unifying theme until we had a better and more clarity as far as the role that the immune system plays. And the role the immune system plays is most of your immune system, like 90%, is directed toward your GI tract. And it was clear that your GI tract is the frontier, if you will, where most of your body's immune system directs its effort. And it was becoming increasingly clear there was some type of abnormal reaction or response that was triggering the immune system and then leading to a sustained stimulus of the immune system. And then in the 1990s, this particular hypothesis was developed called the hygienic hypothesis. The hygienic hypothesis is a notion that perhaps the environment we live in, the amount of exposure to different antigens and bacteria and so forth may well prime an individual to develop this inflammatory bowel disease. And to sort of develop that statement more fully, in places of the world where there is less hygiene, if you will, where water treatment, food treatment, sewage treatment was poor, it was found that, inflammatory bowel disease is exceedingly rare. Whereas in the United States, where these particular issues in terms of water treatment, sewage treatment, and food treatment has improved over the last 100 years, the incidence of inflammatory bowel disease has in turn exploded. So whereas in the early 1900s, inflammatory bowel disease was very rare, in the order of 1 out of 100,000, 2 out of 100,000, now it's like 1 out of 100. So it's extremely common. So it's thought that if a child was born in an environment where they were exposed to more bacteria, that potentially that might diminish the activity of the immune system, and then there wouldn't be as a vigorous response of the immune system that would in turn lead to the development of this inflammation within the GI tract. So that hypothesis was called the hygienic hypothesis, or to summarize it a little bit, little Johnny was not allowed to play in the mud puddle, and as a result, when he grew up, he didn't expose to a lot of different germs and was more susceptible to inflammatory bowel disease.
Is this more prevalent in people that have had transplants that are on immune?
Not necessarily, no. And they're immune suppressed,
That's
as you
right,
know,
they are.
and so it's less common in those individuals, right? And so,
So is this still a hypothesis, or do we really think that plays a role?
It really does seem to play a role, and I won't go into the scientific details, but as a result of this, a number of studies have been initiated using this as a basis. And one of the markers, if you will, of hygiene is the presence of various parasites within the gastrointestinal system. And when these parasites were looked at in more detail, it's found they have a very sophisticated system to modulate the host immune system. They're able to interact and downregulate the host immune system, calm it down, if you will, so that it creates an environment that allows this parasite to live. And in environments where parasites are common, inflammatory bowel disease is exceedingly rare. So preliminary studies have been done and now are being done on a widespread basis. They're called phase 3 studies, and we're participating in one of those studies where we're actually using a particular variety of microscopic parasite whose host is, but by giving it to humans, it's been demonstrated in preliminary studies to actually calm down the immune system and to be a means of treating inflammatory bowel disease. And in this case, the study is looking at Crohn's disease. And the studies look very, very promising. Now, there's some details that have been worked out. You know, in this particular parasite that we're participating on is a parasite. It's called the pig whipworm, and it's specific for pigs. The host is not the human, and so this particular parasite cannot endure and live within a human more than a few days or a week or two. But during that time it does exist, it seems to calm down the immune system, and we're looking at a phase 3 study, and we're participating in that study, comparing individuals who have Crohn's disease. Those individuals, half of them will receive placebo and half will receive these microscopic parasites. And we'll follow them over time and see what kind of response they have.
So in those cases, or in this experimentation, is the logic eventually to figure out what type of down regulators the parasite are making, so that you can then make a drug from that? Or?
Well, yes, and that's another strategy that has been looked at, is that in order for the immune system to cause inflammation, it has to release certain messengers to recruit white blood cells to an area where the immune system believes there's a problem. By interfering with those messages, white blood cells don't have the direction as far as where to go. It's just like a general directing a number of troops on a battlefield, and if you can block the radio transmissions, then there's no way for messages to go to the soldiers to go to a particular location. And similarly in this circumstance, and using that kind of strategy, particular messages have been blocked, and that's what led to the development of the drug called Remicade, as well as another drug called Humira. Now, interestingly, those drugs have been used in other inflammatory conditions, rheumatoid arthritis, psoriasis, but also in inflammatory bowel disease. The interesting aspect about parasites is that it seems to be more specific for inflammatory bowel disease. And yes, indeed, there is some relationship between the parasite and its release of certain chemicals to interact with the host immune system, and that's being studied closely as well. But you know, the parasites have had millions of years to get it just right, and it's not like one chemical or one. It's multitude of interactions that are occurring between the parasite and the host. So it probably won't be able to be synthesized to one message or one one therapy, but that's being studied in close detail. Yeah. Well, you like to understand what you're doing and not just say, hey, gee, that works.
Well, it's complex, so I guess the parasite wants to be able to live there and not kill the host by making
Well, that's exactly right. Create a nice little environment so you can live and not create an unhappy environment. But that's just one example of some of the efforts that have been made as a result of understanding the immune system. Now, we have many other therapies. We're looking at a study using herbal therapy with ginseng and Szechuan pepper. But there's other therapies that are more conventional.
We're going to take a short break.
All right.
And then we'll let you continue
Okay.
there. So we'll take a short break and for some information for you all, and then we'll come back with Dr. Phillips.
Okay.
I had been a practicing orthopedic surgeon for a number of years, and I thought that I was invincible to the multitude of medical problems I saw around me every day. Was quite shocked when I received a phone call telling me that I had cancer of the prostate.
Dr. David Spellberg of Naples Urology Associates is the local specialist in treating prostate cancer with the new CyberKnife radiation treatment.
Once I got myself together, was to do as much research as I could, and what I was looking for was a treatment that would give me the least risk of complications and side effects. And that's where the CyberKnife came into the picture.
Advanced CyberKnife technology, precise. It sends just the right dose of radiation to the cancerous areas. Fast. Each treatment is only 1 hour, non-invasive. This outpatient procedure has almost no side effects.
The day after my treatment, I was out playing golf, and I'm looking forward now to continuing to enjoy a long and happy and comfortable life thanks to the care of my team of doctors and to the CyberKnife procedure.
Learn more about CyberKnife and Dr. Spellberg. Call today.
Welcome back to Dialogue with the Doctor. We just took a short break and we're back with Dr. Raymond Phillips, and we're talking this evening with Dr. Phillips, a gastroenterologist, about inflammatory bowel disease. So let's pick up where we left off.
Well, we were talking a moment ago about therapy in general and how it's been guided by successes as far as understanding what provokes or what causes inflammatory bowel disease. And with that understanding, drugs like Remicade and Humira have been developed that are very effective. Other drugs that are being developed are looking at other means of controlling the inflammation in the GI tract. Of course, we have medications such as Azocol, Lialda, Dipentum, Aprezo. These are all medications that are effective for reducing inflammation, and they're actually time-release devices that allow these anti-inflammatory medication. The active ingredient from all of them is the same. It's called mesalamine, but it reduces inflammation of the lining of the GI tract, either the small intestine or the colon itself. And it's been useful, but what we realized that just reducing inflammation by itself was not really sufficient to really control this, and that because the immune system was what drives this and leads to that inflammation, it was with that understanding now that we've directed therapy toward also trying to modulate the immune system. The trouble is that when you use medications that modulate the immune system, that calm it down, your immune system is not there just for fun. It's there to look out for the presence of infections, to defeat any kind of cancer cells that might develop over time. And so there's the legitimate concern that using these medications might place an individual at higher risk for infections or potentially different forms of cancer. And that had been the theoretical concern. And the issues with regard to infection, yes, there's a slightly higher risk of infection, so we have to be on the alert for that. Fungal infections in particular, or tuberculosis, and those things have to be screened for. Reactivation of certain types of viruses, hepatitis C or B, for example. But the issue in terms of the potential of making individuals susceptible toward cancer has been a great concern with these new medications. And although a great concern, the reality is that just the incidence is not that much higher with these medications. There is a background rate of a higher risk of cancer in the setting of inflammatory bowel disease. Because as I said, it's an activation of the immune system, and that activation can make an individual more susceptible to a form of cancer called lymphoma. So the risk with for an individual with inflammatory bowel disease is about 3 in 10,000 of developing a lymphoma. And so if you begin a therapy like Humira or Remicade for inflammatory bowel disease, that risk might go up to 5 in 10,000. So it does increase the risk, but the risk is not that much higher in absolute terms than the background rate that would occur. So a lot of individuals, though, focus in on that, and they get very, very concerned about that. And it's a concern for the physicians as well. But inflammatory bowel disease is not a trivial disease. It can be absolutely debilitating and can kill an individual. And although there's operations that can be done that are very successful, and ulcerative colitis, if you remove the colon, you're cured of colitis, then you're left with whole new issues in terms of, in the absence of a colon, there's accommodations that need to be made in terms of living with either a ileostomy or having a newly constructed operation that allows a new rectum to be formed. Or in Crohn's disease, operations that can be done to remove the area of Crohn's disease. But operations have been come to realize, at least in the context of Crohn's disease, not to be curative, because if you remove an area of inflammation in Crohn's disease, it will come back at the site of that same operation in a few years' time. Indeed, within a few months' time, there's signs of recurrence of the Crohn's disease at a site of a previous operation. So it's realized that an operation would not be itself sufficient in the context of Crohn's disease to be able to be curative. Now, of course, I mentioned President Eisenhower there earlier. That was an operation to save his life. That was not an operation to cure him. And so that was a different setting there.
So it can reoccur then?
Yes, it can indeed.
Okay.
So the medicines that you're using today, the anti-inflammatories and now the anti-immune system drugs, are those the only two categories that you have right now?
Well, the more precise thing, these drugs that are called biologics, and what I mean by biologics is that they are constructed medications. They're actually antibodies that seek out and latch on to messages, as I was talking to you before. The normal messages your body's immune system sends. So antibodies are constructed to those messenger molecules, and they block them. And so these drugs are called biologics, and they're called anti-TNF, or tumor necrosis factor. And that's what they do. They're antibodies that seek out tumor necrosis factor, block it, and prevent that message from going forward to activate the immune system. That's one whole category that are called biologics. And among those biologics are other types of antibodies that are being developed that have not yet been released. Another whole category of medications that calm down the immune system are drugs called 6-mercaptopurine or azathioprine. These medications actually modulate the entire immune system, calm it down, as you were. Formerly, they were used as chemotherapeutic drugs in the 1960s and 70s, and we got better drugs. And then we realized these drugs in tiny doses can have this effect on the immune system. So they've been used more recently in the last 15 years for that purpose.
So has the probability of a patient who gets Crohn's disease, for example, and ends up having surgery, are we reducing the probability of surgery with the drugs that we're using now? Have we reduced the incidence of...
The preliminary studies, yes, indeed, show that these biologic drugs, Remicade and Humira, as well as these drugs, 6-mercaptopurine and azathioprine, have led to a decreased need for surgery and operations. And so over the last 15 years, that's been reflected in a decreased number of operations being done, colectomies being performed. And so that has substantial change over these last 10, 15 years.
Who is more likely to get these inflammatory diseases? Women, men? Is it anybody at any time of life?
Well, each gender is affected equally.
Okay.
There seems to be two age distributions when inflammatory bowel disease appears. young adults, adolescents or young adults, and then another peak later in life in the 50s and 60s is the two age groups where it seems to be more common, but it can occur at any age. It's rare after the age of 70, but it can occur. It can occur.
For my patients, or our common patients that come in and they may have gastrointestinal complaints, recurrent but not frequent, how do we speak to those patients about whether or not they have such an entity? If somebody comes in and says, you know, I have an irritable incident every 5 years that lasts 6 weeks. I mean, do they have irritable, you know, what?
Well, and you're basically asking, hey, what
How
symptoms
should they-
would alert a person to
Yes.
really be concerned,
Yes.
to bring it up with their physician? And the kind of symptoms that would really be a concern was a clear-cut change in bowel habits that goes on for weeks and weeks, where before maybe 1 or 2 movements a day, and now it's 3 or 4 or 5 urgent movements, increased incidence of passage of mucus, presence of passage of blood, having instances of incontinence, not being able to control the movement and before having an urgent evacuation. One key marker is actually waking up at nighttime to have bowel movements. That is distinctly unusual, and it's not a stress-related event. Irritable bowel syndrome, as you mentioned, is a condition where you can frequently have more frequent bowel movements, but when you go to sleep, it goes away. Inflammatory bowel disease doesn't matter whether you're asleep. You will still have instances of diarrhea. So if you have nighttime awakening, more frequent movements compared to before, it's sustained over a period of several weeks, yeah, it deserves attention. Now, all of us on occasion will get a gastrointestinal infection that's been studied. There's 1.7 intestinal infections per American per year where you'll get diarrhea that might last for several days, and then your immune system defeats the infection and you get back to normal. And so when I'm talking about sustained symptoms going on for a period of several weeks, would really prompt you to discuss with your physician, hey, what should I do to evaluate this further?
We'd like to thank you for coming this evening, talking about irritable bowel and Crohn's disease and inflammatory bowel disease. And
Hope you'll come back again.
Yep.
Oh, they certainly will. Yeah,
Still like you
gastrointestinal
coming.
ailments is so frequent across the United States, and we'll be discussing other topics in the future: irritable bowel syndrome, celiac disease, gluten intolerance. So it just
celiac is a common one.
oh yeah, that's a big one. Based on are we done? Or still done? But based on what you're saying, I might not talk.